So I'm very excited to kick off the clinical core session for us all today. This session will be focused on MBI, or mild behavioral impairment, in early neuropsychiatric symptoms, and is chaired by Dr. Howie Rosen. There will be lots of chances for Q&A today, so please make sure to be active in that Q&A box on Hublot or at one of the stands in our audience. So I'd like to welcome Dr. Rosen to the stage. Dr. Rosen is the Dorothy Kristen French Foundation Endowed Professor for Parkinsonian and Other Neurodegenerative Disorders in UCSF's Department of Neurology. He's an Associate Director for the UCSF ADRC and Chair of the ADRC Clinical Core Steering Committee. Hi, Howie.
Thanks, Hannah. Thanks for organizing all this. It's really been a great meeting, and I hope this is going to be a great session. I am Howie Rosen, and this year I chaired the Clinical Core Steering Committee, which organizes this session. And I just want to acknowledge and thank my colleagues who are listed here, who worked together with me for the last 5 years. Seems like it's gone by really fast. And of course worked with me to organize the meeting, and it's been great working with you. So thank you guys again, and hopefully we'll have lots of opportunities to continue to work. I also want to kind of thank the NIA folks who've been on every meeting, as I'm sure they are, and all the other committee meetings, and in particular Grayson, who did a lot of work to make sure everybody was on task and that all the things came in on time, and really was a big part of why things gelled to the point that they have, and the NACC folks, in particular Hannah, for organizing the meeting and making sure everything for this session worked very well. Thank you, Hannah. Just want to acknowledge that I'm rotating off, and Cindy will be the chair for the next year. And I want to acknowledge Costas, too, who's been voted to replace me on the committee for the next few years, but to really acknowledge him also because he, even without being on the committee, he already helped a lot with organizing this session, and so I really want to thank Costas. Okay, so I just want to take this couple of minutes to kind of frame why we created this session and what our goals are. So I think, many of us recognize that there's a growing awareness that some of the earliest symptoms of a neurodegenerative disease can be behavioral and neuropsychiatric and not cognitive or in combination with cognitive, and that that the diseases that are associated with that early neuropsychiatric presentation go well beyond FTD, where it's maybe most prominently recognized. I think for a lot of us, if somebody had prominent neuropsychiatric symptomatology without obvious cognitive impairment, it would often be a reason to exclude them from centers like ours, and so they wouldn't be enrolled in our studies. And so I think there's a lot we don't know about neuropsychiatric symptoms late in life, and what they might represent in terms of early neurodegenerative disease, and when they might not. One of the things that happened through the clinical task force is we created an opportunity, I think, hopefully, to study this kind of issue more by creating some checkboxes that allow you to characterize people who have what we're calling mild behavioral impairment or early neuropsychiatric symptoms that in your clinical judgment may represent the early signs of a neurodegenerative disease. Just like MCI, they may or may not. But if we don't bring them in and study it, we won't really know the answer to that. And the hope is that we fill a gap that we all know exists within our field and overlaps a lot with psychiatry, which is part of our field. So the goal today is to set the stage for hopefully studying more of this through the ADC centers, to review this concept of MBI and related concepts, make sure we think broadly about early neuropsychiatric symptoms, hopefully we'll have some time to answer questions and discuss it more. And so really the agenda is first this introduction, which I'm doing now. We're going to have 3 talks. I just want to say I feel really grateful and privileged that you really have some of the champions and most prominent leaders in kind of bringing awareness and applying science to this concept of mild behavioral impairment. And so I think we're really going to have some great talks, and I'm also speaking. So you have to deal with that. But I'll introduce the speakers as they come along. And as I said, hopefully we leave lots of time for Q&A. And then the other thing I want to highlight is I think this conference has been great through the REC activities at highlighting the work of emerging researchers. And we wanted to highlight and contribute to that in the clinical core session. So as many of you may remember, we solicited some short presentations, kind of like online poster presentations. And for all those that submitted, we had them create a 4-minute video, which is online and can be accessed from Hublot. There's some great presentations, and if you look through them, you'll see that many of them are quite relevant to the things and the concepts we'll be talking about today. Again, thanks to Hannah for making sure all that works, and the NACC team. And the Clinical Core Committee decided it's always nice to acknowledge, all the work of all the contributors, but to sort of highlight ones that, and to, give a little motivation for somebody doing a good job. So the Clinical Core Steering Committee members reviewed all the submissions, and we scored each one, and we came up with a best presentation, and that went to Elizabeth Rodas from the University of Kentucky ADC, whose presentation is titled Onset of Behaviors Characteristic of Autism Spectrum Disorder as a Neuropsychiatric Symptoms of Alzheimer's and Related Dementias. There's a lot in her talk, from clinical assessment through pathology, and we were very impressed with it. So congratulations, Elizabeth. And as a reward for this great work, we got you this sticker, which says Future President, Washington, D.C., because we think you're a future president of something in D.C. And we also got you this very nice bottle opener, which also is a magnet and also has kind of a snow globe functionality. So it really is like a triple threat of souvenirs. And we also are going to send you a gift card with some money that you could use for whatever purposes you want. So congratulations again, Elizabeth. And now I think we're ready to start. So I'm going to bring up the first speaker, who is Zainur Ismail. Zainur, so I don't have all my intro stuff, but he's a professor at the University of Calgary. He directs several consortia related to Alzheimer's disease and related dementias in organizing centers around Canada. As I said, he's really one of the leaders in advancing the concept of MBI and showing us, providing us with a lot of data that relates to the definition of this concept and how it relates to the disease we're all familiar with. So welcome, Zainur. Thanks for coming all the way here. Really appreciate it, and looking forward to your talk.
Thanks very much, and what a privilege and pleasure to be able to speak to the ADRCs, especially as a Canadian import. And so I'm really happy to be here. As Howie mentioned, we're going to talk about mild behavioral impairment over the next 20 minutes, and I'll bring you up to speed on what this construct is and how it relates to our work as dementia researchers. Now, we know that earlier detection of dementia and AD specifically is a public health issue, exacerbated by the emerging therapies that modify disease. We need to define these and find these people early. Our current paradigm is really to capture that early pathological change before there are substantial symptoms and well in advance of functional impairment in order to administer treatments earlier. And the earlier we administer, the stronger the effect. Now, what I suggest is that we have traditionally held I'm not sure if it's a real word, a cognocentric model of dementia. We start with AD, and we did all sorts of trials in AD, many of which were not successful. It was too late. I saw Ron Peterson here, who has really made mild cognitive impairment lingua franca of our work. Prodromal AD in some in a transitional state between normal cognition and dementia. Moving earlier still, there is subjective cognitive decline in which there may be subtle cognitive changes, but not outside the range of normal objective findings, but with a subjective sense of cognitive decline or cognitive impairment. And then earlier still, normal cognition, in which we have no cognitive symptoms to signal cognitive risk. It's a bit of a conundrum. Every step further away from AD is associated with less signal and more noise. So can we leverage behavior like depression, which is in all the models, for improvement of AD detection? So here is a systematic review on studies of CSF AD biomarkers and neuropsychiatric symptoms. And darn it, it's really underwhelming. So if you look at depression, there are more studies of a negative association than a positive association, and lots of studies with no association. So someone once told me that neuropsychiatric symptoms are just noise, and these type of data are what fuel that type of thinking, unfortunately. So what are we doing wrong? Maybe a cross-sectional measurement ain't good enough. So here is a representative study. There are others like it. 56,000 patients in Finland who presented with neuropsychiatric symptoms. And what they found, we'll focus on the mood aspect of this, that a history of mood disorder is associated with a higher likelihood of developing AD in the 5-year window preceding AD. So if you've had long-standing depression, that risk is there, but it's hard to measure. But if it's usually later life in onset, more proximal to the development of AD, now there's a link. And that's when the discussions of, is this a risk factor or is it a prodromal factor, starts to come in. We start seeing that signal when we're looking at the late onset. So what this suggests to us is that the later in life, the emergence of psychiatric symptomatology, the more likely these symptoms represent the beginnings of a neurodegenerative disease process. Let's further that argument. Here are NACC data, 2 papers from the WashU group and the Hopkins group, both showing that neuropsychiatric symptoms can emerge in advance of dementia and are more likely to emerge in those who go on to develop dementia. So the first are people who have a CDR of 0, and there is an earlier presence of NPS in people with normal cognition who go on to develop a CDR greater than 0. And then very importantly, Kostas Likatsos and Paul Rosenberg, Jeannie Liatsakis, with the paper on the right showing that, as we expected, many people with dementia have a behavioral prodrome. But the number that is really important, I want you to hold this number for a few minutes, is that 30% of people who go on to develop AD have a behavioral prodrome. 30%. And if you think of the population prevalence of AD, that's a heck of a lot of people. That brings us to mild behavioral impairment. Now, we have been working 11 years on MBI. I recall at AAIC 2012, a small group of us, maybe 6 people around a table, discussing this. And then we ran with it. And here we are 11 years later, still building. But on the left, you see our a priori to-do list for MBI. So we wanted to describe later onset NPS as preclinical or prodromal syndrome of all dementias. We know that in FTD, there's a behavioral prodrome. It's baked into the criteria. But, as I've shown you, this applies to other dementias as well. We want to explicitly define the relationship between MBI and MCI. These are not competing constructs. Sometimes reviewers will ask for an MBI versus MCI type of analysis, or people will think they are competing constructs. What's the risk of one or the other? But you can't interpret one without the other. In our lab and in our clinic, we determine a behavioral status, we determine a cognitive status, and that tells us about risk, both clinically and where they would go in a study. So the cognitive status, are they normal cognition, do they have SCD, MCI, or are they impaired to the extent they have dementia? What's their behavioral status? No NPS, transient, fluctuating NPS that don't meet MBI criteria, or emergent and persistent NPS that meet criteria. Now, we've actually developed a triaxial model of dementia that also includes motor and sensory neurological function, but that's for another day. We wanted to standardize the assessment to help define and identify early this target population, hence the MBI checklist, which is now an optional measure in NACC, and I'll tell you just a wee bit about that later on. And then where we are now is to develop novel treatments based on these targets. As mentioned, the core and fundamental criteria of MBI are that symptoms emerge after the age of 50 or in mid and later life, and they represent change from long-standing patterns. So this is something new. These are new behaviors, and that they persist. Ron Peterson did a Dementia Matters podcast a few months ago, and he described, not over-interpreting symptoms if someone had a bad burrito for lunch, I think. And he also talked about the bounciness of MCI. The idea behind the emergence and persistence criteria are to rule out the bad burrito and that bounciness. So then you leverage the risk that is associated with later life emergent and persistent neuropsychiatric symptoms to capture a subgroup who are at high risk. And then we have domains: apathy, affect, impulsivity, impaired social cognition, and psychotic symptoms. So we talked about emergence. Here are some data on persistence. These are memory clinic patients with MCI, and we divided into 3 groups: those with no NPS, those with NPS not meeting MBI criteria, and MBI. And what you can see from the Kaplan-Meier survival curve on the left is that those who meet MBI criteria have a much shorter and lower dementia-free survival over 4 years. And you can see there's substantial difference in those hazard ratios between groups with neuropsychiatric symptoms. So here are people who have behavioral symptoms, but if we actually subdivide them based on MBI criteria, we identify a group that are much higher risk. And by the way, there is risk associated with the other group, but it doesn't really differ from that of no NPS. That's really important. I have biomarker data to show on this in a moment. So we'll go back to depression. Whatever it is, however you find it, however you call it, it's in every model. If you're going to convince a neurologist to include one behavior, it's going to be depression. And what we found here is if we actually plucked out emergent and persistent mood symptoms, then lo and behold, we've got a pretty nice risk, hazard ratio of 1.76. Importantly, of the MBI affect converts to dementia, 85.5% developed AD. If you then used the amnestic MCI subsample, it was 91.4%. By the way, out of all the 5 MBI domains, despite depression being the one in all the models, it is the domain with the lowest risk relative to the others. I'll show you a little bit more on that as well. The paper on apathy was just published in December in Barry Greenberg's journal in TRCI. And we have multiplicative interaction tests, hazard ratios from the Cox proportional hazards regression, and then the Kaplan-Meier survival curves. And I put them there to illustrate the differences between and within strata. So the blue in the Kaplan-Meier survival curves are those with normal cognition, and the brown are those with MCI. Again, knowing your cognitive status when you then superimpose your behavioral status is really important. As expected, the MCI group has a greater progression rate and lower survival, and the normal cognition less so. However, within stratum, differences are profound, more so in normal cognition. So perhaps approximated by the area between the curves, between the blue and the brown. You can see that when neuropsychiatric symptoms emerge in cognitively normal older adults and persist, they have a great risk for incident dementia. They certainly do in MCI, but even more so when they emerge in normal cognition relative to people who don't have those symptoms. And the multiplicative interaction tests show that very, very nicely. The paper on the right, just published within the last couple of weeks in Nature Mental Health, shows something similar. But in this case, now I've separated the Kaplan-Meier survival curves for MBI and neuropsychiatric symptoms not meeting MBI criteria. Now, psychosis, of the 5 domains, psychosis has the greatest risk. When it emerges in late life, it's a big deal. And associated with incident dementia. Even in that high-risk group, when you ensure that it is emergent and persistent, that hazard ratio goes up to almost 4. It is extremely high. So when we add behavior to cognitive risk, then we can improve our prognostic powers at any cognitive status. So let's zoom out now and focus on subjective cognitive decline to predict incident MBI. These are data published a couple of years ago, also from NACC. Looking at cognitive status, so we have normal cognition and SCD, and your behavioral status, those who have MBI and those who do not. And what you see is this ordinal increase in likelihood of developing MCI or dementia at 3 years. And at normal cognition, the superimposed MBI group has significantly greater risk, and in MCI, the same thing. The lowest group are those with normal cognition and no MBI, followed by subjective cognitive decline and no MBI, followed by MBI and normal cognition, and MBI and subjective cognitive decline. From an MCI perspective, these data were published in Neurology last year, showing that when you identify symptoms that are later life, in this case, and especially those that persist, you are more likely to have progression to dementia. And the bad burrito for lunch comment, MBI in MCI is associated with a lower likelihood and a lower rate of reversion to normal cognition. So we talk about progression. We don't always talk about reversion. You take your MCI group, and we know that depending if they're a population study or a clinical study, the progression rate is different, right? In clinical samples, it's much higher, and there are meta-analyses that show out in the wild that actually fewer people progress than we thought. Many revert. If you take that MCI group and superimpose MBI and you capture that high-risk group, they're not going to revert back to normal cognition. They're more likely to progress. So this is a quantifying behavior, identifying the behavioral risk, which is completely non-invasive, that can really refine and enrich a sample for risk. Now, does it enrich a sample for biomarkers, right? That's the big question. Well, I'll suggest to you that it does, and there are plenty of data emerging to show that. I'll give you some of it. This paper was just published in Neurology in the last couple months. And we looked at both cognitively normal and MCI participants. And the three comparator groups were those with normal, with no neuropsychiatric symptoms that were either not emergent or impersistent. So, and then the MBI group. And what we see from the Kaplan-Meier survival curves there is the risk and the dementia-free survival was substantially lower, significantly lower in the MBI group than the no NPS group. And the NPS not meeting MBI criteria did not differ from those with no symptoms. So that begets the neuropsychiatric symptoms are noise. If we measure it conventionally, then we might be getting a bit more noise and less specificity. But if we are precise and say, hey, these are newer onset symptoms, they represent change, and they persist, you got a high-risk group. To put it in a cognitive perspective, we also looked using linear mixed effect models, the association between baseline status and then MBI and NPS not meeting MBI criteria, and cognitive change. And what we found that there was greater impairment and decline in both memory and executive function in the MBI group versus the NPS not meeting MBI group. And then finally, plasma p-tau 181 also differed such that the MBI group stood out and the NPS not MBI group didn't. So a biomarker study with plasma p-tau 181, which I think, in the absence of 217 and 231 is pretty good at prognosticating dementia or detecting it, AD specifically, and that the MBI group captures a higher proportion of people that have elevated plasma p-tau 181 than the other groups. So a biomarker enrichment strategy that is non-invasive, free, simple, takes about 7 minutes with current measures. Now, we'll get to measurement in a moment. Here are CSF data in 2 different studies, in Memento, memory clinic patients, and in ADNI. So they are similar but different. Real-world memory clinic patients with MCI, and then the ADNI, which are selected, again, for some sort of memory impairment, and again, lower on the vascular burden. And the studies were the same. So we did cross-sectional regressions, longitudinal linear mixed effect models, Cox proportional hazards regressions, all the assumptions were met. And what we found that is in mild cognitive impairment, MBI was associated with Alzheimer-related changes, including a lower A beta 42 and a lower A beta 42 to 40 ratio, greater p-tau and tau, and then the home run, I think, is the higher p-tau to A beta 42, which is probably, and some might, and please correct me, Henrik, et cetera, if I'm wrong, the p-tau to A beta 42 is very powerful at predicting incident dementia within even 2 years or sooner. And these are CSF studies, so more precise than the plasma studies. And so, what this tells us is that the estimates for CSF AD biomarkers in MCI participants, they differ based on our behavioral status. That MBI performed better than conventionally measured neuropsychiatric symptoms, and thus can have really important downstream effects on how we identify risk clinically, how we identify people for observational cohorts, and for clinical trial enrichment. Unfortunately, the Skyline study didn't go, but we were to identify preclinical AD using, and they expected a 90% screen failure rate. Perhaps if we operationalize MBI into screening criteria, we might be able to reduce that screen failure rate, reduce costs, and more industry partners can participate in trials. Here's the MBI checklist, which is now an optional measure in NACC. And the idea behind the MBI checklist, it measures all 5 domains. It takes about 7-8 minutes, ideally completed by a study partner. And inherent in the MBI checklist is the fact that symptoms are later life emergent, representing change, and persistent. So we can use a single time point measure to identify MBI, whereas historically we've had to use multiple time points to determine if symptoms were transient or persistent. And finally, to wrap it up, MBI is in the NIA-AA framework and clinical staging. Again, the framework should stimulate efforts to develop new behavioral measures that monitor functioning in individuals with preclinical AD, to determine how they align with the ATN system. And we know that behavioral symptoms are in stage 3. They are also in stage 2. So stage 2 represents a change from individual baseline within the past 3 years and persistent for at least 6 months. So here we go, a change, emergence, persistence. Although cognition is the core feature, mild neurobehavioral changes, for example, changes in mood, anxiety, motivation, et cetera, and they cite the MBI criteria, may be, that the presentation may be neurobehavioral rather than cognitive. And what we've shown is that 30% of cases, neurobehavioral symptoms should have a clearly defined recent onset and persist, and cannot be explained by life events. So the bad burrito for lunch. Thus, to finish off, an individual may be placed into stage 2 on the basis of neurobehavioral symptoms alone, that is, without evident cognitive decline. So if we want to extend our reach into identifying early those who are at risk for AD or may already have AD, absent cognitive findings to signal that risk, if we leverage behavioral symptoms appropriately, we can then identify better that early risk group. And I'll stop there. Thank you.
Thank you, Dr. Ishmael. We are running a little over, so I think we'll save your questions to the discussion at the end, where we'll have all speakers up on stage. Howie?
Thanks, Zainer. We have a lot of burritos on the West Coast, so it's good to know I won't be automatically placed in a risk cohort just for that. The next speaker is Jennifer Gatchell, who is a geriatric psychiatrist and assistant professor of psychiatry at Harvard Medical School, and is from the Mass General Hospital and part of the ADRC group at MGH. And again, has been a real light in bringing science and knowledge to this area. Very glad to have her. Thanks, Jennifer.
Thank you. Thank you so much, Dr. Rosen, and to the Clinical Core Steering Committee for the opportunity to speak today. As Dr. Rosen mentioned, I'm a geriatric psychiatrist at Mass General. And so I jumped at the chance to kind of present on a topic that's near and dear to my heart, which is considering psychiatric disorders versus early neuropsychiatric symptoms of a neurodegenerative disease. How might we think about this, and why does it matter? So these are my disclosures. So briefly today, I'll provide a very brief, following Zainer's excellent presentation of late-life neuropsychiatric symptoms and mild behavioral impairment, illustrate and highlight how there's a clinical overlap with what we might consider primary psychiatric disorders. And then finally, present a possible hypothetical framework by which we might think about distinguishing these things and why it might be important in terms of clinical tools and emerging biomarkers. And finally, leave you with some future directions for research, which will hopefully help to make this somewhat muddy distinction a little bit clear-cut and helpful for research and patients moving forward. So neuropsychiatric symptoms are multidimensional, as we've heard briefly from Zainer, encompassing multiple affective and non-affective domains across the spectrum of dementia syndromes from preclinical to clinical stages. And historically, we have measured these symptoms kind of borrowing scales that really were meant to detect and to follow standard DSM-5 or DSM psychiatric phenomenology. And only more recently, with the advent of MBI, the NPI, and other skills that have been more geared towards recognizing symptoms that might be distinct in older adults and actually might represent a preclinical or prodromal stage of a neurodegenerative disease. So neuropsychiatric symptoms have widespread impact. They're incredibly prevalent. They're associated with disease pathology, and they have negative implications for patient and for care partners. So they're associated with impaired functional performance, decreased quality of life, and actually with disease progression and increased mortality. And in some, they also increase care partner burden and increase the burden on the entire healthcare system and for the patient care partner dyad. And despite these symptoms being incredibly prevalent across all clinical stages of dementia and having this clinical impact for patients and care systems, we have an incomplete understanding of biological mechanisms in neurodegenerative syndromes. And as a result, we have a lack of effective treatment options. So often we're using repurposed agents that have potential adverse effects and really are ineffective at targeting these neuropsychiatric symptoms. Also, our incomplete understanding leads to a challenge in recognizing and assessing these symptoms in late life, and that in turn can lead to missed opportunities for early recognition and prevention of dementia syndromes. So recognizing this gap in our clinical knowledge and in the literature, Dr. Ismail and colleagues, as he mentioned, starting from a brain trust meeting at one of the AICs, developed and operationalized mild behavioral impairment checklist. So I'm not going to reiterate kind of the core basis of emergence and persistence in late life that he really emphasized in his presentation. He presented some biomarker studies related to that show that MBI is a predictor of both prognosis and also can be a predictor of underlying disease pathology. And indeed, there's a growing body of evidence supporting this. This is one study from the BioFinder 2 a study in which 50 cognitively unimpaired A-beta positive individuals were assessed for MBI, and it was found that MBI was associated with higher tau PET signal as well as CSF phosphorylated tau 181. And so this and other studies really support MBI as an early clinical manifestation that may be related to core AD pathology, even in the preclinical stage of AD and other dementia syndromes. So I'm not going to summarize in the context of this talk the wide body of literature that's growing and emerging, studying multimodal biomarkers in relation to MBI and more broadly NPS. And that can be the focus of a whole other presentation, and it's also the focus of collaborations between the iStart NPS and biofluid biomarker PIAs. But in some, in preclinical and prodromal populations, MPS and MBI have been found to be associated with CSF, plasma, and also neuroimaging biomarkers of AD, including amyloid species of phosphorylated tau, A-beta tau ratios, as well as atrophy. In addition, in our own work in the Harvard Aging Brain Study, as well as in other cohorts of preclinical individuals from ADNI, from BioFinder, from the Mayo Clinic study of aging, we found that not only broad MBI, but specifically depressive symptoms, apathy, anxiety, are associated with AD pathology, and as well as an accelerate cognitive decline. We've mentioned that it's important to recognize these symptoms are incredibly prevalent. They have a lot of clinical impact for patients and caregivers. And now we have the MBI checklist. We have the construct of MBI that can help us to think about these symptoms and what constellation of symptoms may in fact be harbingers or markers of an underlying disease, neurodegenerative disease. However, this is an excerpt from the MBI checklist for 2 of the affective domains. If we line these up with classic DSM-5 nosology for major depressive disorder, as well as for how we think about constructs of bipolar disorder in late life, we can see a number of similarities, including lack of pleasure, feeling that you're a burden, having low mood, having decreased interest, and also for some psychiatric diagnoses, including persistent depressive disorder, these symptoms persist beyond 2 weeks. So therefore, we have some overlap with the MBI criteria of emergent and persistent. So how do we think about this? And is it in fact important to make this distinction as clinicians and clinical researchers? And as Dr. Ismail pointed out, classically we think of frontotemporal dementia, or FTD, as being associated with early and prominent changes in social emotional comportment. And in fact, these clinical symptoms may overlap with classic DSM-5 disorders that might meet criteria or come close to meeting criteria for a number of disorders ranging from major depressive disorder to autism disorder to even personality disorders. But this extends beyond behavioral variant FTD. And indeed, neuropsychiatric symptoms in ADRD more broadly may also resemble core psychiatric disorders. So getting back to, is this an important dichotomy? Is this an important distinction to make? And how do we think about making this distinction? So I'm going to present to you one hypothetical framework of thinking about this. And this may be thinking about what stage of the dementia syndrome are we recognizing these symptoms. So first, thinking about these symptoms presenting at the stage of a known or recognized dementia syndrome. So at this stage, we may think that these symptoms are a manifestation of underlying neurodegenerative disease pathology. This pathology might be the same or distinct from that pathology that's underlying cognitive decline. The symptoms at this stage could also represent a combination of it could also represent comorbid or premorbid psychiatric illness superimposed on characterological traits, resulting in a distinct symptom constellation or presentation. So an example of this may be an 80-year-old patient with probable Alzheimer's disease dementia who doesn't have a past psychiatric history, but develops apathy, anxiety, and irritability in the context of a dementia syndrome. And so in this case, we may more likely think that these are manifestations of the underlying neurodegenerative disease, possibly superimposed on personality traits, such as in this patient, dependent or avoidant personality traits. So in this case, I would argue that the distinction and the characterization are important because they have implications for disease management and personalized management. They can perhaps predict how likely these symptoms will respond to conventional psychotropics or disease-modifying therapies, as well as non-pharmacological interventions, and can help us develop a patient-centered or biopsychosocial formulation of the way to approach these symptoms. In the future, hopefully, with better understanding of neurobiology, they can help us develop more targeted treatments for these behavioral symptoms themselves that are driven by neurodegenerative pathology. And what about NPS in late life that we find in individuals who have unimpaired cognition or very early stages of subjective cognitive impairment or MCI? So in this case, it's a little bit more complicated. But broadly, we can think of these NPS, specifically if they meet criteria for MBI, if they're newly emergent, as manifestations of the underlying neurodegenerative disease, again, with shared or distinct mechanisms from cognitive decline. And again, superimposed on the patient's baseline or neuropsychiatric baseline. So just as someone might have a cognitive baseline, they might have a neuropsychiatric or psychological baseline in which these symptoms are occurring. In that case, we may think of them as being predominantly related to the neurodegenerative disease. An alternative option could be that these symptoms in late life actually represent a primary psychiatric disorder. So we all know that many individuals who present with major depression, bipolar disorder, anxiety in late life, they may never go on to develop dementia, or at least in their lifetime, they will not go on to develop dementia. And so in this case, we may think about the neurobiology as being predominantly non-neurodegenerative. However, these symptoms can confer increased risk or decreased neuropsychiatric reserve for later development of cognitive impairment. So this is an at-risk population, but perhaps this is not the population that is imminently going to go on to develop cognitive symptoms in the short term. And finally, I want to highlight to you a population that I have a particular interest in, and that I also want to be sure that we don't ignore in the context of ADCs and in kind of thinking about this classification. And this is the situation, what if both phenomena are occurring? So it can be the case that someone has a psychiatric illness that's early in onset and they age with that illness, but they also develop a comorbid neurodegenerative disorder that manifests as a change in the symptom presentation or new nature of presentation or decreased treatment response in late life. So again, not ignoring those patients because we know they have a psychiatric premorbid history, that they could also have MBI coexisting. And so I would argue that this has important implications for early detection, early recognition, for management and prognosis implications, and for patient and care partner quality of life in terms of making this distinction, but more broadly characterizing these phenomena through the patient's life course. So now that I've told you that it's important, the importance of making this distinction and how might we go about doing it? So how could we actually try to disentangle, is this likely related to a neurodegenerative disorder? Is this more likely a primary psychiatric disorder, or both? So really we can draw on some keys in clinical presentations that may be atypical from what we might consider kind of standard psychiatric presentations of individuals who are presenting in earlier midlife. And this can be some of the following. So obsessions that are not distressing to the patient, so that are different from what we observe in classic OCD, or compulsions without obsessions, depression with marked apathy or anxious distress, depression with a lack of anhedonia, what we might consider atypical features for a major depressive disorder. Also, things that we might consider atypical are things that are newly emergent, changing from baseline, hearkening back to the MBI criteria. So that is a late age of onset of anxiety, mania, OCD, psychosis outside of a mood episode always triggers kind of the need for further evaluation of not only an emerging dementia syndrome, but potentially medical etiology or both, and something that could be reversible or partially reversible, possibly. Other red flag symptoms may be a loss of empathy, emotional detachment, lack of distress in relation to the psychiatric symptoms. Other atypical presentations, for example, sustained mania in the absence of depressive episodes, schizophrenia without complex delusions or hallucinations, progressive cognitive impairment, as I mentioned, lack of a treatment response or treatment refractoriness, any signs of motoric abnormality on exam, and also family history can provide an important and salient clue as well. However, in some cases, as Dr. Rosen will mention in his presentation, this is indeed a false dichotomy, and psychiatric symptoms, even if they are more likely related to a neurodegenerative or neurodegenerative plus psychiatric etiology, are in fact more typical in their presentation. They can actually map quite well onto DSM-5 terminology, where the age of onset, that kind of these being kind of new or different in later life, may be the only outlying criteria. And in fact, an example of this complexity is in C9 or F72 mutation carriers who may present with psychiatric prodromes. So there's some key principles of assessment, some of which I've highlighted already. A few others that I want to touch upon are medications, overt and covert substance use, obtaining a family history, a physical and neurological exam, and also considering measurement. So I'll get into this a little bit at the end, but how do we measure these symptoms? So we want to always obtain the individual's perspective, but also a care partner or care partner's perspective, because we know that lack of insight does occur in preclinical stages and prodromal stages of dementia syndromes. And this is lack of insight not only for cognitive symptoms, but can also be lack of insight for behavioral change. And this can occur beyond behavioral variant, FTD. So a care partner-based history is essential. Ideally, an independent friend or relative that is affectively removed from sometimes that affectively charged dyad could provide another perspective, as well as objective assessments of emotional behavioral functioning. And so, for example, like an emotional recognition paradigm. And some of these emerging topics are actually covered in some of the pre-recorded presentations of kind of this area of how might we assess these symptoms in a more objective fashion. So not just say, did you have a bad burrito for lunch, but how many did he in fact have in the past 2 weeks? And this is what I want to highlight in terms of study partner report versus self-report of these assessments. So these are our data from the Harvard Aging Brain Study in a largely cognitively unimpaired population of 150 older adults, in which we found that study partner report of apathy, of more apathy, was associated with PIB and entorhinal cortex and inferior temporal cortex tau, versus we didn't find any associations with self-report. So some neuropsychiatric symptoms indeed lend themselves more closely to study partner report or objective assessment, such as apathy. Other key principles of assessment are just ruling out other medical or contributing etiology, some of which I'm shown here. So we want to consider that this could be an emerging degenerative disease, but also want to rule out, again, potentially reversible or partially reversible causes. Infectious and also inflammatory, limbic predominant encephalitis, and delirium. And part of this workup would include considering neuropsychological function, laboratory evaluation, monitoring medication changes, and considering neuroimaging. Now, in terms of the principles of assessment, we don't have clear guidance in this regard, especially for patients who are presenting in a psychiatric setting, so outside of a memory clinic, in terms of when would we probe further, when would we carry out routine imaging outside of a standard workup. So I would argue that if there's any notion of an atypical presentation, atypical features, in my practice, if there's any notion of an older adult presenting kind of with the first onset or first episode of this syndrome, I will definitely probe further. In doing so, it's important to collaborate closely with the neuroradiology, with a neurologist, because oftentimes findings may be subtle on standard imaging reads and just kind of read that the scan is normal, but you really want to provide take a quantitative look at structural and functional changes in the brain. And consider genetic analysis. Again, there are no clear guidelines for this as of yet, and it really would not be practical to screen every patient who we suspect is having an underlying degenerative condition for an FTD mutation, early onset AD mutation. But if there's an autosomal dominant pattern of inheritance, or for FTD, if there's at least one first-degree relative with FTD, ALS, or an early onset neurodegenerative disease, and the patient's presenting with a psychiatric syndrome, we may want to consider genetic screening. And indeed, a future and ongoing area are developing such consensus recommendations in clinical research and in clinical practice. So this is one excerpt from Ducharme et al. And their work in Brain 2020, representing work from the Neuropsychiatric International Consortium for FTD, trying to provide consensus recommendations for distinguishing behavioral variant FTD from psychiatric disorders, including one social cognition test, specific volumetric analyses of imaging, including FDG PET, but not over-interpreting non-specific signals, the potential role for CSF neurofilament light, or NFL, in distinguishing behavioral variant FTD from a primary psychiatric disorder, and then cases when we would consider screening for the CN or 72 mutation. And more broadly, there is and there's going to be an increasing role of biomarkers to aid the clinical tools and the exam tools that I mentioned that can tip us off to atypical presentation. And these include CSF markers of A-beta, tau, phosphorylated tau species, plasma measures. And these have a high specificity, as we heard from Zainer, and as we know for AD. As of yet, we don't have similar biomarker panels that are specific or for other common or rare neurodegenerative disorders, but this can help us to distinguish AD from non-AD etiologies. And as I mentioned, there's increasing evidence for plasma NFL correlating with CSF NFL and helping to make this, this distinction with a primary psychiatric or predominantly psychiatric presentation. So in conclusion, I've kind of told you through this talk that MBI and MPS are early clinical features of a neurodegenerative disease. They are related to underlying disease pathology. But it is important to consider differential diagnoses and considering whether or not the etiology is predominantly neurodegenerative, if this is a primary psychiatric disorder, or if both things are occurring. Some of the things that can help us along these lines are atypical features, study partner report, objective assessments, and biomarkers. And I would argue again that this is an important characterization, if not a distinction, because oftentimes the picture is kind of blurry and patients may not fit into a solely neurodegenerative, solely neuropsychiatric bucket, but carrying out this characterization does have important implications for diagnosis and patient-centered care and management. Now, in the future, ongoing areas of work that will shed more light in this area and hopefully help us to further operationalize criteria are determining whether or not neuropsychiatric symptoms travel with core AD pathology or have a distinct neurobiological mechanism, and also measurement properties. So how do we measure persistence? How do we do this objectively? We've shown that, and we've kind of observed in our own studies, that doing this remotely and frequently, we do see a lot of movement in self-reported symptoms. So this is kind of a future area, is how do we measure and analyze those data. And also developing formal MPS diagnostic criteria in the context of degenerative illnesses. So we've done this recently for apathy and psychosis, or I should say the working groups for IPS and for iStart in collaboration with IPS have done this, but this is really needed for other NPS, so we can all be on the same page as what are we talking about in terms of the apathy or psychosis syndrome in AD or related dementia. And also importantly, what will really be the gold standard to hopefully set the stage for kind of future clearing in this area are longitudinal perspective studies in diverse samples using consensus diagnostic criteria and incorporating biomarkers and clinical outcomes. So that will really be the gold standard they want to aim for. So thank you again to Dr. Rosen for the invitation to talk, and for the Mass ADRC, Harvard Aging Brain Study colleagues and participants, and the iStart MPS Executive Committee. Thank you.
So if it isn't abundantly clear, the UDS and the NACC provide us with a longitudinal, well-characterized cohort in which to answer these questions, one of many. So the talk that I'll do, and I'm going to be assisted by my mentor and colleague Bruce Miller and my other colleague Virginia Sturm at the end, is to talk a little bit about the specificity of neuropsychiatric syndromes associated with different proteinopathy, or proteinopathic etiologies, and what we do know and what we don't know about that. So I think, this is sort of how the way I conceptualize this talk is that, if there's a limited but quite broad set of neuropsychiatric syndromes with which one can present, the model in our minds for many of us is that, if disease A, let's say it's Lewy body dementia, versus Alzheimer's could be disease B, or FTD can be disease B. They're each associated with an overlapping but unique set of neuropsychiatric symptoms. And I think this is borne out and certainly comes from a lot of clinical experience going back many, many years at this point. And I think also we recognize, and that's the discussion of any kind of discussion of prodromal really invokes this kind of model, which is well established now, that whatever we're seeing once the disease is well established at a dementia phase is, of course, the result of a long process of biological evolution and early symptoms that evolve into what we all recognize and have characterized for many years. And I think there's an underlying assumption that if you look back and you look for neuropsychiatric symptoms, that what you see in the prodromal stage will have some sort of a relationship to what the diseases will eventually develop. So if you start to see things that look like FTD, maybe the person's developing FTD, and if you're interested in FTD, that's what you should be looking for in the early phases. And similarly for Lewy body and any other dementia. So I think it's a very reasonable first pass assumption at how to approach these things. And the goal of this talk is really just to examine very briefly what we know about these assumptions and to sort of first talk about what we know about disease specificity and how much we do and don't know and how much there is, and also highlight some developments in assessment that are going to lead to a better characterization of these early prodromal symptoms and help us know exactly how much this model applies and in what stages. And I'll mostly focus on FTLD and synucleinopathies, which provide nice examples, but we'll talk about AD by comparison along the way. So let's first focus on the sort of this stage. If we actually look at dementia using the dementia stage, using the best corroboration we have, which is neuropathology, what do we know? So, in this case, for FTLD, this is work, I did a long time ago, and others in our group, and other groups as well, highlighting the fact that it looked like FTLD was characterized by a unique set of behavioral features, in this case using the NPI, that really differentiated in AD. Some of those things like disinhibition and elation, which overlaps with symptoms of bipolar, for instance, pretty rarely seen in AD. Others like apathy are commonly seen in AD, but much more prevalent in FTD. Almost every behavior FTD case we've seen seemed to have apathy at the time, for instance. So around the same time, we published work looking at pathologically confirmed cases that showed what we're expecting, which is that among the symptoms that differentiated path-proven FTLD versus path-proven AD included these social conduct disorders, is how we characterized it at the time, like disinhibition, and clinical histories that indicated emotional blunting, dietary changes like overeating or chewing or hyperorality, and that personal conduct things like apathy, that's how it was characterized at the time, were indeed seen a lot in AD, but much more prominent in FTD, and so this is neuropath. So that's older data. And skip a lot of years, we didn't know that much about, I think, synucleinopathies until more recently. And again, there's work coming out in the last few years that speaks to that differentiation. This is an analysis, this one again from our group, looking at path-proven DLB versus FTLD. Now, I'll note that all the DLB cases in this cohort had comorbid AD, and I think that's a prominent theme is there's not a lot of pure DLB in path cohorts that we have knowledge about yet. But that said, I think represents a lot of the cases that we see. And what they found is that indeed synucleinopathies were associated with a lot of hallucinations, more than in any other group, but that two forms, the form of FTLD caused by TDP-43 also saw hallucinations quite frequently, much more so than an FTLD-related tau. Of course, that's an interesting question, why that differentiation? But these are the facts of the findings. So, not that much specificity, but a little bit. When you look at delusions, which is, I think, less, it's put forth as less of a specific criteria, but often when I think of delusions, I do think of synucleinopathies a lot. And actually, we saw more of those in TDP-43 than in synucleinopathies. So, I think the take home in terms of frequency is that, yes, synuclein pathology is a little bit more likely to be associated with hallucinations, but delusions are pretty common in several of these pathologies. Now, one of the kind of really useful pearls is it may not be in the frequency, but in the types of symptomatology that may have additional specificity. So for instance, the types of hallucinations seen in synucleinopathies were definitely statistically significantly different than the types you saw in FTLD. So, and that's highlighted in kind of this graph over here, where synucleinopathy patients were more likely to endorse shapes and colors as part of their hallucinations, or sort of shapeless hallucinations, as well as hallucinations that involve people and movement, like things moving in the corner of your eye, also the sense of somebody being there when they're not. All these things turned out, based mostly on retrospective chart review, to be more prominent in synucleinopathies. And in addition, delusions related to misidentification or a place being not what it's supposed to be or being moved or things like that, those were more common in synucleinopathies. So beyond frequency, maybe the details are helpful in this differentiation. So, and I'll just highlight another. This is from a cohort in Brazil where they also looked at pathologically confirmed cases, comparing, in this case, AD to synucleinopathies, and they saw the same thing, that synucleinopathies were associated with more frequency of hallucinations, and the higher the Braak staging for Parkinson's proteinopathy, for synucleinopathy, the more likely the person was to have a hallucination. So that's a brief kind of look at the sort of dementia state of things and looking at neuropathologically confirmed cases, which says, yeah, the syndromes do look different, but there's a lot of overlap, and you have to be careful, certainly not just looking for the presence or absence, but you need to think about the content, which may be helpful. And there's a lot of other food for thought in there as well. What about this early phase? What do we know about that? Well, I think probably the most important thing to say is that we still have a lot to learn, and I'm just really highlighting the existence of several of these large consortia in which many of these centers are involved that are working to develop the data. So one is ALL-FTD, which is looking at early FTLD. Another is the NACC consortium and the PPMI, Progressive Parkinson's Markers Initiative. And these are all looking prospectively, starting with people who are at high risk for a neurodegenerative syndrome, based on a combination of features depending on the study. In ALL-FTLD, we're really using the presence of an autosomal dominant mutation as the main risk to look prospectively. And in the other studies, they're looking at a combination of things, sometimes genetic mutations, also genetic variants with high risk, as well as clinical syndromes with a very high risk, like REM sleep behavior disorder. So I think through these studies, we're going to learn a lot about the early neuropsychiatric symptomatology, and it may or may not, change what we say about, think about this model that I'm that I've put up here. I'm just going to give you a little taste of what we know from some of that early work. In our group, for ALL-FTD, this was led by Megan Barker from Ted Huey's group at Columbia, where we recognized for a long time that there are established criteria for FTLD that specify certain neuropsychiatric features which are important for the diagnosis. And basically what Ted's group wanted to do is say, in prodromal cases, people who are clearly evolving behavioral symptoms, but not yet at the dementia stage, what clinical symptoms do they have? So they really characterized all of the symptoms that people had or did not have, and then compared the frequency with controls and also with Alzheimer's disease to arrive at a set of symptoms that seemed to be characteristic of prodromal FTLD. And they wrote a paper which basically described these symptoms and proposed that these might be a set of criteria you could use for prodromal FTD. And what I highlighted in red here is some of the features that actually overlapped with the criteria that were published in, I think, 2011, describing FTLD in general. So the point of this slide is then to say it looks like the prodromal phase does look like the well-established phase, at least using methodology like this. But what I'll point out is they were looking at a whole group looking for any symptoms that might have occurred at any phase in the prodromal illness. That doesn't mean that the first symptom that a person might have is actually going to reflect these symptoms. And I'll point out irritability and agitation as an example of one that wouldn't have been on the criteria, in the early criteria, because it's very common. But I'll show you an example of a case where 3 years of that was present before the more characteristic symptoms emerged. So this is an example of a 53-year-old person who was part of these studies and so therefore was seen prior to any development of any behavioral symptoms. And for the first 3 years, all they had is irritability, getting more angry with their spouse, bickering, and kind of being argumentative with other family members, and that was it. And the first year, it was just attributed to kind of life things like one of their kids having trouble in college or things like that. And, by the end of that 3-year period, they were saying, this is not going away. And they kind of lost a job and had to get a new job because they flew off the handle, this kind of things. But by age 56, 3 years later, you're starting to, hear the symptoms that are a little bit more characteristic, making these annoying sounds when eating, like clicking sounds, and people having to ask them to stop, and they won't, and clanging the fork, or getting kind of caught up in an internet scam and almost spending a lot of money. These are typical FTLD features. And then saying socially inappropriate things. That's socially, loss of social warmth. And you can read the rest of the slide, basically. And by age 62, they really developed a full FTLD syndrome, BVFTD, and were diagnosed with that. And so that's, almost, 10 years of progression, the first 3 years with very nonspecific symptoms, even though they would have been a great example of a case that looked like prodromal FTD in the study I just described. So the other kind of case I want to highlight is an example like this, which sort of focuses on some of the what Jennifer was saying, where, first of all, these cases may not look mild, as this first, irritability might have been characterized. And they may not really look much like FTLD necessarily. So here's a case where we had who I saw because of, in his late life, around his 50s, he started to develop these delusions, which I think are kind of typical of schizophrenia, like that his home was bugged and that there was this guy named Guido who had put these bugs in, and now Guido's dead, like a very elaborate sort of system of what's going on and how he's being persecuted and monitored. He thought there were like movie cameras in his glasses, so, allowing other people to monitor what he sees. He thought he was a sex god and would go to other neighbors knocking on the door saying, I'm here, time, for the sex you wanted. And he had hallucinations, people hearing voices, no visual, people telling him to do various things. He had what I think is a fairly typical Capgras syndrome, thought his neurologist was killed and replaced by another neurologist. This was not me, as far as I know. I was spared this fate. It was a different neurologist. But anyway, this is how he presented. And I actually thought, well, maybe he has early Lewy body disease. And then we discovered several years later the C9orf72 mutation, and that's what he had. And in fact, after about 3 years later, after that discovery, he started to develop typical symptoms of FTD, particularly overeating, apathy, and he developed motor neuron disease, as a fair proportion do. And this was his image. So when you look at his MRI, it looked quite normal, and by most measures it was normal. But you see sort of little hint that, and this is a quantitative image looking at every voxel and comparing it with a large group of norms, and you could see that there's a region in the thalamus which looks to be prominently atrophied, and that's a feature of C9 disease. It's sort of an example of, I think, what Jennifer was talking, and that we heard earlier, where these sort of quantitative measures, especially when combined with clinical measures, can be useful ways of starting to move people from what sounds like a late life psychiatric disorder. I think this met criteria for late life delusional disorder, the way it's written in DSM-5, and decide, well, in this case, I think it's neurodegenerative, even maybe without the mutation, but of course that's important. So that's a good example. So now I'm going to kind of jump over to synucleinopathies. And actually, I'm looking at work here that was done a little bit before these consortia. Jim Galvin led a nice analysis looking at NACC data. And he looked at both well-established Lewy body dementia cases as well as prodromal Lewy body cases, mostly defined by early cognitive symptoms and RBD and things like that. And so what he showed is sort of a similar thing that we've been talking about, that hallucinations were quite common in Lewy body syndromes, and we already talked about that. But I think the relevant thing is when he looked at what he called the prodromal phase, that was not a prominent feature that differentiated them from others. And really he found some very non-specific things like depression and anxiety that were present in this early Lewy body cohort compared with controls. And when you look at actually the NAPS data, the NAPS is still in a very early phase where there's not been a lot of long-term follow-up or conversions to higher levels of symptomatology. But so when you look at the baseline data, you might expect to see a lot of hallucinations or other Lewy body specific features, and you really don't. The most prominent symptoms in the NAPS cohort, and of course these are prominent in normal people too, of course, or people not affected by neurodegenerative disease. Anxiety and depression were by far the most common features, and hallucinations were seen pretty rarely. And in fact, there have been other studies looking at prodromal synucleinopathies. One of these from, I think, Sweden or another Scandinavian country, and another from the U.S., both of which showed that hallucinations do occur in the prodrome. But I think the study at the bottom from Chowdhury et al., which is particularly instructive because it showed that hallucinations are pretty uncommon in the early phase of the prodrome and seem to come up over time. So it's fair to say that maybe at some point the prodrome of synucleinopathy starts to look the way you expect in synucleinopathy, but it may not look that way in the earliest phase. And again, I'm making the same point with Lewy body syndromes, that similarly these may not be mild and these could be quite significant. And this is from a published case that I found was a very nice description of a woman who was seen by a center at age 62, and they already knew she had symptoms in her late 50s of her first onset of significant depression with suicidality, responsive to therapy, quite significantly affected, not working, et cetera, but then went back to work after a successful treatment after several weeks at least. And then she had a second episode at age 62, which is when they saw him, clearly couldn't do her chores and things like that. And then she had another episode at age 69, and there they detected a little bit of Parkinsonism and sweating at night and constipation, started to worry a little bit about a synucleinopathy. And that's when they did imaging, and they showed this area of hypoperfusion on SPECT in the occipital region, and a DAT scan looking at dopamine transporter activity, which was a little bit low. They called it kind of borderline. And her Parkinsonism resolved after they changed her medications and got her off meds that would increase her risk of Parkinsonism. And her symptoms went away again with management. But then, age 75, she presented with another episode of confusion and hallucinations after aripiprazole, which was again started in the context of another depression. She improved with medication adjustments, but at that visit, she had a clearly abnormal DAT scan. And she, by another year, she had progressed to the point where they were comfortable making a diagnosis of dementia with over Parkinsonism, which was dopa responsive, and she was diagnosed with DLB. So again, for more than 10 years, you have symptoms that sound like very typical depression with, at that point, with that analysis, borderline biomarkers, but very concerning. But nothing atypical otherwise about the syndrome. I think a very nice other example saying when we talk about these prodromal symptoms, it's not just about MBI. It's about quite significant syndromes that can look just like a DSM-5 consistent syndrome. So I'm kind of put this model just to sort of summarize what I think we're seeing, but it's very speculative and very early, but at least it kind of acquaints us with the idea of what we have to be open to and looking for. So what we may end up learning as we study this more is that indeed that the earliest parts of the prodromal phase, people may develop a pretty non-specific set of symptoms like anxiety, depression, and that at some point in the prodrome, indeed, it may be quite common that people start to evolve and develop more symptoms that give you more specific clues about what neuropathology is developing until they sort of resemble the dementia syndromes that we're all more familiar with. It's a speculative model, but I think if this is the right model, it really kind of supports and highlights the idea that you can't go looking for only the specific syndrome that you're expecting, that we have to be open to these very early, fairly non-specific symptoms. And I'll just make a couple of other points. I think we also have to be aware of and include symptoms that are not usually in our high list of symptoms to look for. This is an example showing that, late onset alcoholism was much more common in retrospect in an FTD cohort compared with an AD cohort. But, and now the last two slides, I just want to kind of highlight, before Bruce. We're still good on that? Okay, anyway. On the last two slides, I just want to highlight this idea that I think we are doing work and we need to do work to sort of measure and quantify these things more objectively. Some of that work is being done through the FTLD module, for example, where we're capturing symptoms using standardized instruments like the interpersonal reactivity index and the revised self-monitoring system, which clearly are specific for FTLD symptomatology and sensitive in the early phases. This is work from Kate Rankin and our group showing that in people who have a mutation but are only at a CDR 0.5 level, often just based on behavior, these measures are abnormal. And I think we do need to get to this scenario where we can measure things objectively using, not just through informants. And this is kind of a nice example, which is, not something we're going to be implementing immediately, but this is work from Virginia Sturm's lab, who you'll hear from in a moment, where they actually coded facial expressions during exposure to various emotional stimuli through movies, and then looked at across different disorders and showed that in C9 mutation carriers who were in the sort of very mild phase, they had a very excessive emotional facial response to these videos compared with controls and asymptomatic cases. And they also mapped the relationship between the representation of the facial expressions and the motor cortex and found a very disorganized relationship compared with controls. So this is just one of many examples showing that, if we move into a phase of trying to objectively measure changes in social emotional processing, it may help us to get some specificity back, maybe in these very early phases. So I think that's the end of my portion, really highlighting that I think there are specific symptomatology related to each proteinopathy, but there's a lot of overlap. You have to be careful to think about the content of the specific symptoms, that the very early prodrome may be quite nonspecific, and that some of our future opportunities really involve objective quantification through well-designed informant-based measures as well as direct measurements of social-emotional functioning. So in the last few minutes, I wanted to introduce my colleagues who are going to bring us back to the narrative. So much of what we know about neurodegenerative disease is through stories. And one of the presenters is going to be Bruce Miller, who's the director of the Memory and Aging Center, and was one of my main mentor, who really pioneered a lot of this work, highlighting early neuropsychiatric symptoms and how they evolve into FTD. And really, I think what he taught me, and I think is reflected in what he'll be doing today, is you don't really understand the symptom unless you know the story. And I think he's going to read from work he's working on with Virginia Sturm, kind of illustrating that. Virginia Sturm is a colleague who's been at the Memory and Aging Center for several years now, runs the Clinical Affective Neuroscience Lab, and her job is really to develop some of these objective measures to look at socio-emotional functioning, to take it away from the subjective. And they're going to talk about early symptoms of empathy that evolved in a right temporal degeneration case that, again, it's hard to imagine how you would have captured these symptoms other than by listening really closely to what brought the patient into the clinic. So without any more further ado, I'll bring on Bruce.
Thank you, Howie, and the ADRC community. I'm Bruce Miller, a professor at UCSF, and I'm going to read with Virginia Sturm a book that we've written entitled "The Brain Most Human."
The chapter that we'll be reading from is about empathy.
I met Thomas and Susan in 1999. 2 years prior to the visit, Susan began to witness the crumbling of her marriage. She knew that Thomas was no longer the same man that she had married. I asked, "Can you give me an example of something Thomas did that made it clear to you that his behavior had changed? She took a deep breath and told me the following story. The incident she described was so upsetting to her that it steeled Susan's determination to find a neurologist who would take her concerns seriously. It was a sunny afternoon in California, and Susan was working in her garden. As she was trimming her rose bushes with her garden shears, she struggled to cut a thicker branch. Suddenly, she screamed and gripped her hand. Blood ran down her arm and up to her elbow, where it seeped into the sleeve of her rolled-up blue plaid shirt. She began to sob. When she finally peered down at her hand, she realized that she had accidentally cut off the tip of her finger. Thomas watched without moving from his chair. When his wife's crying became more intense, however, he yelled for her to stop. Thomas's reaction shocked Susan, and she looked at him aghast. Between sobs, she urged him to bring her to the hospital. After a long pause, Thomas reluctantly agreed. Rather, however, than rushing to the car, Thomas returned to the yard and retrieved the garden shears. He walked to his neighbor's house, rang the doorbell, and when the door opened, he said flatly, "Here, you can use these while we're away. We're going to the hospital." Then he returned home, got into the car with Susan, and pulled out of the driveway. Susan cried throughout the car ride, as troubled by Thomas's indifference to her suffering as she was by the unrelenting pain in her finger. As she finished telling her story, Susan looked at Thomas and then at me. Her eyes were glassy and full of sorrow. I returned her gaze with a heavy heart, feeling a mixture of sadness and horror at the way she had been treated. Thomas sat straight in his chair, staring ahead. His face remained unexpressive, and he was unaffected by his wife's distress. From Susan's story, it was evident to me that Thomas could not feel or understand the excruciating pain that she had experienced when she cut her finger. His loss of empathy was so dramatic, I was certain that there must have been a devastating change in the brain.
In Thomas, there was notable atrophy in several brain regions that are critical for empathy. He seemed to live in a cocoon devoid of feelings, and loss of tissue in the anterior insula made it difficult for Thomas to sense his own emotions and the emotions of others. Atrophy in the right, more than the left, anterior temporal lobe and amygdala also disrupted his ability to recognize and produce emotions. The right anterior temporal lobe is a key hub in a network that stores semantic information about people and feelings. When the right anterior temporal lobe does not function well, people have trouble understanding emotions because they no longer know what emotions look or feel like. Degeneration in these regions interfered with Thomas's ability to simulate the feelings of his wife and daughters when they were in distress. Without his feelings to guide his thinking and actions, Thomas increasingly relied on old rules that he had learned rather than adapting flexibly to each situation as needed.
Later in the chapter, since meeting Thomas, I have seen many people in our clinic whose first symptom of frontotemporal dementia was loss of empathy. Through studies of people with FTD, we have learned much about empathy and the empathy circuit in the human brain. The potential this research has for understanding and improving the human condition, however, is just beginning. It's the responsibility of scientists.
Thomas's story illustrates what can happen in a family when empathy fails in one of its members. Although we often consider empathy at the level of individuals, empathy is also essential for the success of larger communities and even societies. Groups can vary in the empathy that they feel for people within and outside their membership or borders. In recent years, declining compassion for others in politics, business, education, and other areas of society has led some to sound the alarm about an empathy crisis. A lack of empathy at the societal level can have devastating consequences and lead to civil unrest and wars. When we begin to see other humans as very different from us, empathy is harder to feel and cruelty comes more easily. We need to find ways to highlight rather than reduce our shared experiences. By finding commonalities with others, empathy around the world can flourish.
Thank you.
Thank you.
That's it. So we left less time for questions than we planned, but we might have time for a few, 3 or 4 minutes till lunch.
Yeah, we'll
Okay.
welcome Dr. Ishmael and Dr. Gatchell back to the stage.
Are there any Hublot questions?
Not currently.
Okay. Julio?
Testing.
That
Thank
is
you.
Julio.
Great, compelling presentations. Thank you, Javi, for putting this together. I think we can bring the neuropsychiatric symptoms to the center of our endeavors, our research endeavors. And we've been talking about integrating care and research. And we want to follow and see what happens with people who are treated with anti-amyloid therapies and see the natural history. I think I will take this opportunity to make a call to the NACC and NIA to also register or track how we're treating neuropsychiatric symptoms. And not just a list of medications, but also non-pharmacological interventions, because that type of data can really transform the experience of our patients.
Julio, could I make a quick comment about that? Jennifer Gatchell really pointed out how far behind we are with pharmacological therapies for the neuropsychiatric symptoms of neurodegenerative diseases. And I think the data is very clear that as all of these diseases progress, the neuropsychiatry becomes more and more dominant. And Jeff Cummings, among others, has really emphasized that we really do need more clinical trials targeting the symptoms of people with neurodegenerative disease and very severe psychiatric syndromes. I think this is an area, echoing Julio, that we really need to do more of as a community.
Maybe I can just add one comment. I think we have a preconceived notion that if you have psychiatric symptoms or neuropsychiatric symptoms, we treat with psychiatric medications. And do we really know that that translates into the care of those with neurodegenerative disease? DSM tells us that these symptoms should not be better accounted for by another medical condition. Is an amyloidopathy, tauopathy, TDP-43, etc., a medical condition? And if that is the case, do we then treat with dementia medications or some sort of combination between treatments for the psychiatric symptoms traditionally and the neurodegenerative disease? Yvette Chalene has that lovely paper showing that escitalopram reduces amyloid burden. And I think that's a real signal that we need to revise our preconceived notions, our nosology, and our constructs.
Yes, I'll just add on to that and to Julio's comment and Dr. Miller's comment that also keeping track and monitoring of the emerging area of neuromodulation for treatment of these symptoms, given that we know the adverse effects associated with psychotropic medications and the lack of efficacy, that there are a number of studies using non-invasive brain stimulation to target these symptoms. And that will both inform and make use of our understanding of brain circuitry that underlies behavior such as empathy and different affective symptoms, regardless of what diagnostic category we want to place them under.
Question from the virtual audience. I lied earlier. Elizabeth Rodas asks, first, so she comments, wonderful presentation. Has there been any work looking at the MBI checklist and relationships with functional performance in daily tasks, such as measured in the FAQ?
Thanks for that question. And the answer is no. Part of the MBI criteria are that there should be some sort of functional impairment, secondary to these new onset emergent and persistent behaviors. However, we have no measures that will identify this well, because they're all developed for people with dementia or potentially with MCI. So this is work that still needs to be done.
Thank you. Gladys Maestre from the South Texas ADRC. And I have a comment and a question. I was a little bit triggered by not hearing anything about the challenges on working with diverse populations and adversity in late life and family values and support and neighborhood contract in the manifestation, treatment, progression of neuropsychiatric symptoms. And in particular about the comment, which I understand, but the objective assessment of neuropsychiatric assessments, I think is imposing a lot of, it is needed, but it's imposing a lot of needs for the ADRCs in the nation. Thank you.
Yeah, I totally agree, and I think that I mentioned briefly in my talk, but not in depth enough, like the biopsychosocial formulation, biopsychosocial and cultural formulation. So, and I think that that is worthy and a needed talk and part of this endeavor, because the biomarker results that I presented largely in non-diverse populations. So we, number one, don't know if those biomarkers would be as sensitive in those populations. And number two, how we measure and how we ask about psychiatric symptoms is amazingly different across cultures, and how we would think about managing them. So that context in the real world setting, I think, is a huge gap and also a huge opportunity that we really need to address. And we have the ability to do so at ADRC, at the South Texas Center.
Thank you for acknowledging that.
Thank you.
And then we're going to just have one more in-room question. I'm sorry we're running over time, but I encourage you to find the speakers after the session is over.
Yeah, hi, Russ Swerdlow, Kansas. Thanks to all the speakers for a great session. Howie, in thinking of your construct, you made a good point that behavioral variant FTD can have a very long prodrome. Where would you draw the line between behavioral variant FTD prodrome and I guess what some of us called FTD phenocopy syndrome?
So Jennifer asked me this. So I think one of the problems that we have is we don't really know something is a prodrome until we look back and we've seen the outcome, especially without the full array of biomarkers that we need. So I think the first answer is I use the term prodrome advisedly because as a concept, we know it's a real thing, but I don't think we always know it when we see it. And that's the role, clearly biomarkers are critical for that. I think phenocopy, right, which I'm sure most know what it is, but it's basically the scenario where people meet criteria for FTD and have lots of changes in their behavior, but their imaging and neuropsychological testing and longitudinal follow-up show that they don't change for years often, and therefore it seems unlikely that they have a neurodegenerative disease. I think the case I showed, actually, at least by imaging, could have been called FTD phenocopy. The paper I referred to characterized him that way, and he was an example of, there was no biomarker to tell us he didn't have FTD phenocopy until the C9orf72 mutation was discovered. And I think FTD phenocopy, then somebody else did a paper which showed we have 20 or 30 FTD phenocopies and we looked for C9 and only a couple had it, right? And that was a result you would have expected, right? So I think FTD phenocopy probably represents a lot of different biological mechanisms, some closer to what we think of as non-neurodegenerative psychiatric illness, and some falling closer into our camp. And I think at this point, that's the critical importance of enrollment of a broad array of well-defined cases and longitudinal follow-up. And the NACC is going to be a great place to do that, or similar studies, because we'll layer on biomarkers as they become more and more available, which will, I think, redefine all of these terms.
Can I make a quick comment about that? I know you're running late, but there's a recent paper by Adam Staffaroni that, led by Howie, Adam Boxer, and Brad Beauvais and all FTD. And they showed that in C9 carriers, there was often leakage 15 to 20 years of neurofilament before the likely onset of neurodegeneration. So I think it points out, at a very biological level, some of the phenomenology that we see in C9, carriers, and why so many of them, at some point, we wonder about whether really they are on their way to a neurodegenerative disease because they fluctuate and they never quite, reach neurodegeneration until later, but they do. And I think this is really, an important merging of biology with phenomenology.
Thank you, Bruce. So that concludes our questions for this session. Thank you all to the clinical core session speakers. If we could give them a round of applause.